Okay. So when we are talking about this one, then always start with don't, oxygen, dextrose, naloxone, and then thiamine. After that, we will start with whatever the treatment is, basically depending on what the overdose was about. If it was alcohol, then you have to start with the 12-step program, family therapy, and then sport. Usually these kind of questions they do like to ask in the NACOSKI, but you can be asking the questions like, what will you do if the family wants to involve? So do the family education, psychotherapy, addiction counseling, MET, CBT, contingency management, like they have to continue their medication in that one, okay? Then medical management, acute detoxification, physiological agents to aid, and then there is a clinic, like it's not only in Ontario, there is in Manitoba as well. It's in different provinces. So RAM could be the one of the thing, and harm reduction, comorbid psychiatric, and then the Ministry of Transportation is very, very important to think for if they are driving. So I think we discussed pretty much everything up to this level. Now comes the alcohol. Alcohol is one of the very important, and there is very many things that do assess in alcohol. When it comes to alcohol, you need to know what are the medications, what are you going to give, because if the patient is taking medication, using alcohol, and they want to stop them alcohol, so what medicines you give. So on the basis of that, what is the medication you have to start with? And then if there is a withdrawal, then what medications you give? If there is a overuse, then what medications you give? So let's start with the alcohol use disorder. If they are taking it too much, now they are asking for a medication. It's a family practice thing. So in that cases, we go for naltrexone. And I do give it, I do prescribe it. But in that case, you have to tell them, oh, you have to cut down the alcohol, otherwise the other counseling part. But you can start the naltrexone. Like they'd be like asking, oh, can I start any medication that can help me stop my alcohol use because I always have a craving for that. So in that case, you can give the naltrexone. Then comes the acamprosate. So how do you decide? Either you have to go for naltrexone or either you go for acamprosate. By the way, disulfiram we don't use it anymore, so I'm not going into the detail of that one. Just between naltrexone and acamprosate. So when we are talking about craving, so it says this one is moderately effective in reducing craving, but this one it says decrease craving and it's more useful in maintaining the abstinence. So if someone just stopped 2 3 days ago and now he's having craving, in that case acamprosate is the one that's more helpful, and they can give you a scenario, be like, oh, he started 2 3 days ago and now he's having this craving, and what did you do prescribing? So in that case is go for acamprosate. Although naltrexone is good too, but they say it's a moderately effective. So more effective is acamprosate. And in your scenario, they can give you both of the options and asking you to choose between one. Okay, so you need to know which one is good for which one. So this one, naltrexone, is basically the patients who do intensity or the binge, like they just drink, oh, it was weekend, I just drink a lot, now I want to stop using it. So that cases can be started if still consuming alcohol. So in that case is going for naltrexone. So you can use this. On the basis of that, you have to decide. And there is a question where they give you alcohol use disorder and giving you both of them, and then you have to see which one you have to choose. Okay, this is an important MCQs. Then we already discussed the Wernicke-Korsakoff. In that one, you have to know how do you diagnose which one is Wernicke and which one is both of them together. When it comes to amnesia, then it's Korsakoff as well. Then what is the alcohol withdrawal? The basic protocol is giving diazepam because they can present with the seizures and observe them, giving thiamine as usual, and then sportive medication. Then if this is a withdrawal seizures, as usual, they say diazepam. But if this is age more than 65, in those cases, don't give diazepam. Use a short-acting benzodiazepine. And if they have respiratory, sorry. So they can ask you in which cases you don't have to give the diazepam. So it would be more than 65, liver disease, asthma, respiratory. That's what they're looking for. Or if the scenario they can give you, the patient has liver disease. Liver disease, what will you give? So in that cases, you don't have to give diazepam, short-acting benzodiazepines. Usually the short-acting benzodiazepine is diazepam, but they did not mention it. It means you can use anything else. Lorazepam, then haloperidol, if the hallucination is there, then again the diazepam. Admit to hospital still in withdrawal after 80 gram of diazepam is there, delirium tremens. And then, as I said, you need to know which stage of alcohol he is at. Okay. It can be asked. Then comes the withdrawal. Sorry, this is the same thing, I think. Yeah, alcohol intoxication. So I would suggest if you can make a small note or like a small, like, you know, short note on your side and then write down there what are the main drugs for which one of the thing. So in the intoxication, usually we give only fluids. We don't go for any medication. Stabilize the patient if there is a reduced level of consciousness, monitor vomiting and all that. Then IV crystalloid fluids. Monitor for the signs of alcohol withdrawal following the detoxification. So usually we go for that one. Then comes the intoxication. So you just need to know how which level and what is the diagnosis. If it's a misuse, if it's a withdrawal, if it's an intoxication, and what is the treatment for it. Then comes the opioid. Opioid is one of the most presentable topic, sorry, most presentable question that can come because a lot of people are using T3s. T3 is basically Tylenol 3, which contains codeine in a very high level. So people do misuse that one, okay? Or they can buy it from outside as well. So in that case, is what is the antagonist of those ones? It's a naltrexone and naloxone. So you need to know can be used with the alcohol dependence, and naloxone is basically used for life-threatening CNS. So as we already discussed in the don't, we go for naltrexone. That's why in the naloxone used for life-threatening CNS, like respiratory depressant, how do you find out? If you check for the pupil, it's constricted pinpoint pupil, it can give you an idea that this is taking opioid. That's very easy to, like, if someone presents, I personally do that, and it helps like save a lot of time. Short half life, very fast acting opioid receptor, and then induce the opioid withdrawal symptoms later on. So in that cases, we do generally don't go for naloxone, but we go for naltrexone. But you can use the naloxone in those cases where you feel like he has taken opioids too much. Now he's having respiratory distress. In that case, naloxone works really fast. Then the what are the types of opioids? So it can be heroin, morphine, oxycodone. It's for your own knowledge because in any word can be used. Like people like me, I don't personally know what are the different names of the opioid. So that's why I try to like read it. So if you can remember what are the opioids different name, the heroin, the fentanyl is the other name, then meladone, maybe methylphenidate. So these are all of the one. Acute intoxication, direct effect on the receptors of CNS, causing the constricted pupil, sex-derived decrease, sedation, perception, vomiting, GI motility decrease, and then respiratory distress. Everything decrease. As we already discussed, this is a CNS depressant. Okay. So medical emergency where people who have respiratory distress going on bradycardia, in those cases we go for don't. Same don't. ABCs, IV glucose, and this is naloxone. So why we are going for naloxone? As they said, it works really fast, and treatment, intubation, and the ventilation. Naloxone drip can be started without naloxone. Okay. Opioid has a longer high life than naloxone, may need for observe for the toxic reaction. Then comes the withdrawal. This was intoxication where they take a lot of it. Now comes the withdrawal. It was a CNS depressant. So when they stop it, what will happen? Everything will increase. Chills, fever, sweating, diarrhea, pupil dilation, piloerection. As you can think of, everything is increasing. So, it can give you an idea how to approach this. In this one, what we do is basically giving methadone, buprenorphine like an oral opioid. So you have to give them opioid to stabilize them. Simple, because he was having withdrawal, so giving opioid. Then you can always use clonidine and all of that to go for the withdrawal side effects. Monitor the withdrawal severity using the clinical opioid withdrawal scale. That's very unlikely. Classic opioid overuse is basically RAM. Then comes the use disorder when people is using too much. How do you find out? Usually checking for the blood screening. Okay. Long-term treatment may include the maintenance with the methadone and buprenorphine. Then how do you check that he was using it? Maybe the friend is taking it, he's taking it over the counter, taking it, buying it illegal, and all of that one. So usually the long-term methadone is given, which is basically a very long period of time. So he does not buy it or use it over and over again, or the buprenorphine is the one that's used. Then comes the cocaine. Although these all are important, but I would suggest like there is one of that one that is not given here. One of the drug. What is it called? Sorry, marijuana. So marijuana is the one that is usually very, 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 very important because it's very common. Okay. So in that one, we don't have it here. I will find some slides. I think I do have in my notes or somewhere. So we will do that tomorrow. Okay. Because it's very, very important. If you find something, you can always see it from there or share it with other. Then cocaine is basically street name, same coke. I remember it because any word can be used. Rock, snow, freebase, flake, any of that one. So then it is also a CNS depressant. So everything will be, if you use an intoxication, pressured speech, restlessness, tachycardia, mydriasis, sorry, it's a CNS and stimulant, so it can increase everything. Then the prolonged may result in the paranoia and the psychosis, leading toward the tactile hallucination. One of the most presentable thing that can lead you toward this is cocaine and conjunctival redness. In overdose, what happen is because of hypertension, tachycardia, because it is a stimulant, so everything will increase. So in that cases, then what we do is basically giving IV diazepam to control down. Benzodiazepine is always to slow down. Beta blockers, I would suggest make a note on the side and just write down the names of the medicine. It's an overdose, this medicine. It's a withdrawal, it's this medicine. That's what I did for myself, so I can just quickly read that one. Then the withdrawal is basically initial crash, increase sleep, like everything will decrease because he was taking the increase one, now it's having decrease. So in that one, withdrawal, diaphoretic, and then withdrawal, insomnia, this one. Complication is relapse, so only the supportive treatment. Treatment of cocaine use disorder, in that one, we only go for relapse treatment or mainstay of the long-term treatment. No pharmacological treatment. This is very, very important. In the cocaine use disorder, we don't give any treatment. Even in the withdrawal, we don't give any treatment, like any medication. Then complications, you can always remember this one. Then comes amphetamine. In the ADHD people do like to ask the Ritalin. I do like to Adderall. Like these are the street drugs. And then in this one, what happens? Euphoria, it's a stimulant. It can increase the activity. So in this one, the treatment is basically giving benzodiazepine. Then the cannabis also has other name delta 9, lelra, hydro, cannabinol. So cannabis is more than enough. You don't need to remember the other thing. In this one, there's one line here. Where is it? Give me a second. This one here. So how does it present? So you can make the diagnosis. Simple. Okay. So in this one, you have to go for the cannabis is basically presented with tachycardia, conjunctival redness, dry mouth, sensorium, increased appetite, and muscle relaxant. Then comes the hallucinogen, all of this LSD, PCP. Usually the question that I saw, it was from like they give the name PCP. That's why I said you need to remember the names. PCP, and then the management of acute intoxication is sport, reassurance, stimulation, benzodiazepines, antipsychotics, and seldom, and then minimize the use of restraints. Then long-term adverse effects could be, dependency and psychiatric involvement disorders. Then comes the club drugs. In this one, you just have to remember, like, main effects of it. If you can remember everything, it's your choice. Mechanism is not important. Skip it. Just remember the effects if you can, and then adverse effect is opposite to it. Okay, like MDMA is important. It can cause the altered sensorium. The mainly is feeling of well-being, like feel like good. You start feeling good. Ecstasy that causes the empathy, feeling for everyone, very feeling very good. Then the gamma hydroxy, which is also an ecstasy, so it is also giving a euphoric feelings. Then flunitrazepam, that's causing sedation. So in mainly this one is for the decreased sexual inhibition. Ketamine is basically causes hallucination and dissociative state. Then methamphetamine is basically this causes the increased activity. So that's why a lot of people use this one. The amphetamine is very important and ecstasy is very important. Then you can read the other two as well. What are the date rape drugs? GHB, flunitrazepam, and then ketamine. Formication is very important. Why? Because of the tactile hallucination, and it's only common in the drugs. So usually there is no tactile hallucination in any kind of disease. Tactile hallucination is only in the drugs. Emerging medical use of the hallucinogen. Many hallucinogens are currently used for the therapeutic use, but still not used. Malingering and factitious. I think this one is the one. Malingering is something that you intentionally putting or false to get some gain. Factitious is not for the gain. Okay. So if you are looking for some sort of gain and you do something like he wants to, let's suppose if I'm working someplace and I show that I'm sick and just to get a leave, like, off from work. So this is my gain off from work. So what I did was it's malingering. But in factitious, I just acted as if I'm sick, but there was no gain in it. Like I went to workplace, I start acting like drowsy and this and that. It's like but my thoughts, there wasn't anything that I want to gain. But if I go to workplace and I was thinking that if I act drowsy, they will not give me extra work. Now that's malingering. And in MCQs, if they are looking for something, they will give you the benefit. If it's a benefit, then it's a malingering. If there is no benefit, it's factitious. Okay, simple. They will give you a very straightforward MCQs. They will not make it complicated. You have to make the concepts. Then comes the somatic and relative disorders. Let's do the disorders and then medication we'll do tomorrow. Brief, regular. Then this one we have to go for the GP. It's a family practice thing. They go follow up, good communication, limit the physicians involved, or make the family involved more. Focus on the functional environment, CBT, psychomotor, and then psychotropic drugs. Somatic symptom disorder in this one is basically somatic symptom disorder with a predominantly pain, like behaving like he has a lot of pain and illness, anxieties. So you need to know the difference between this one. In the somatic symptom disorders, they usually go for somatic symptoms is basically for the pain. For those who has somatic symptoms, is primarily pain. I have been having abdominal pain. I'm having some sort of uh, headache or something like that. So in that cases, you do all the blood work and everything. And when you tell them, they do understand. They do have insight for it. But when it comes to illness anxiety disorder, they usually if you give them illness like it comes with a lot of depression. He start thinking of some sort of disease, or he's like it's somatic was there was pain. You go to the doctor, you get the treatment, you feel fine. Now but you still have pain again later on in 1 or 2 weeks again. Okay, but in illness they do have some sort of pain going on, but they think that there is underlying if he has abdominal pain, he thinks